Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta Krishnan, medical editor at MIMS Learning, and I'm pleased to welcome GP Dr. Tim Sanders. Alongside his clinical role, he is a clinical lecturer in rural medicine and urgent care in the rural Eden Valley in northeast Cumbria. He also runs the Stabilisation and Treatment Awaiting Transfer course and the Urgent Medical Care course. Welcome, Tim. Pleased to have you with us today.
Oh, thanks for having me.
So what would you say has changed in the last 5 to 10 years that make preparedness for emergencies in primary care so much of a pressing issue right now?
What's really changed is not that primary care is suddenly seeing a load of new or different emergencies. It's always been something that's been there in the background of the work that we do, but we're being asked to hold risk for longer and more often now. And what I mean by that is we're seeing more complex, frail patients living in the community, and at the same time, the wider system just has far less elasticity to cope with their developing needs. Ambulance response times are longer, emergency departments are really full, often at saturation point, and that then backs up into ambulances having to wait in queues outside the emergency departments at times. So the assumption that help arrives quickly, we can't hold that as an assumption anymore. And that's shifted the role of primary care a bit. We're no longer just identifying emergencies and handing them over. So it's not just the recognition and the initial sort of treatment, but it's then following through and reassessing the patient and providing and initiating treatment, not just recognition. And in that context, that preparedness, it's not just about sort of rare heroics. It's about being able to do the basics really well and repeatedly as well, at times under pressure and in the context of having to continue to offer the other aspects of the primary care service at the same time. Because if I'm in another room looking after a patient who's unwell, then I've still got all my patients who are booked in to see me sitting in the waiting room. Trying to manage that workload is a real challenge.
Interesting. And we know how ambulance response times have changed since the pandemic. So how has this impacted primary care teams when they see patients who are acutely unwell?
It turns assessment and referral into a more of a situation of assessment, then stabilisation, then monitoring, then risk management, potentially for an unknown length of time. Although thankfully the reality is when we ask the ambulance service how long they're going to be, they are able to give us a bit of an indication of what the wait time is, even if it's within broad brackets or bracketed terms. But clinically that means that you need to not only just be able to recognise the sick patient, but then be able to monitor and recognise deterioration, recognise that deterioration at an early stage and start to treat reversible causes, hold the patient safely. And that's anything from giving and having the capability to give oxygen, to managing airways if there's airway obstruction, to giving bronchodilators, to be able to give glucose or fluids if it's appropriate, or and the list goes on. And it's also repeated observations to monitor the impact of those treatments. Core life support principles absolutely central to what we do, and having a really solid, if you strip it back to the basics, the primary survey matters certainly as much as it ever has, more than it ever has really now, because we're needing to not just identify those primary survey issues, but also then respond to them and then monitor the response to the treatment we've given and then make further adjustments. So the teams that cope best are not those who have the most equipment, but they're the ones who are really confident with their ABCDEs and who can spot deterioration early and know how to use those interventions that they have available to them to buy time most safely. Operationally, it means you need space and staff, and you need a plan as well, and who stays with the patient and who's going to, as I said, who's going to run the rest of the surgery, who meets the ambulance, who speaks to the relatives, who's going to do documentation. How do you reach back to your local teams, either critical care outreach teams or maybe your local ED consultant to ask for help, to ask for advice as to how you might manage the complex needs of the patient who's in front of you. That really needs a team-based approach. And the great thing about primary care is that we've been doing team-based approaches really well for a long time. So we respond to these challenges really well. It has changed the clinical reality. On top of that, I think because it is really important psychologically, it really increases that moral load as well. And people are feeling responsible for the outcomes. And the longer the period, particularly in a low resource environment, the greater the risk for that to become very stressful, for people to experience moral injury in terms of, I thought that I should have been able to do something and I wasn't able to. That can be quite traumatizing for clinicians as well. And I think we're still traveling a little bit of a journey through people recognizing and realizing that that's their new reality.
Realistically speaking, what would you say are the typical emergencies that a primary care team is most likely to encounter?
It's a good question, and I think there's a bit of a mismatch between perceived risk and actual probability and what we see, and what people worry about and what the common reality is. And I think what we worry about, what I worry about, I do a lot of thinking about this as part of my sort of academic and professional work, is thinking about this, but I still worry when I go into work about these halo events, these high acuity, low occurrence events, cardiac arrest in the waiting room, or as happened, in my more distant past, somebody falling through the plate glass window of the front door and sustaining a really severe laceration. And thankfully, these events are very low occurrence. They're very stressful, they're very memorable, and they're very emotionally loaded, but they are very rare. And what we actually see much more often is, I wouldn't like to describe it as more mundane, just more commonplace. And we're seeing people with respiratory illness who are deteriorating, people with asthma or COPD exacerbations who are deteriorating. They were not so unwell that they needed to call an ambulance when they booked their appointment that morning, and they've come down to the surgery, but they've got worse and they're worsening in the waiting room, or they've just been hanging on. We're seeing sepsis in all age groups, but sepsis particularly in older adults, where it's maybe difficult for that to be identified at an earlier stage, and where deterioration can happen quite abruptly. People walking in with chest pain or acute confusional states, those are the sort of the common presentations. I mentioned respiratory illness already, but children with respiratory distress as well can be really, really intimidating to manage. And I fundamentally believe if you can manage the common scenarios well, if you've got a good framework, a good structured assessment that's based around good basic life support and immediate life support principles, you've already built the foundations needed for those high acuity, low occurrence events. And because the physiology is the same, and the primary survey approach is the same, the structure is the same, and the critical actions that you need to undertake if you identify disordered physiology or an obstructed airway, all of that stuff's the same. And if we can practice that, rehearse that, then whilst the stress response within us is the same as well, we can manage that stress response by rehearsing and practicing those skills. The great thing is that we don't just have to do that once a year on a course, or by doing a bit of CPD. We can be rehearsing that as well as within our teams by looking after these sort of slightly lower acuity events as well, and just reflecting on those when they happen within the team.
What does it mean on a practical and on an ethical level for a primary care team to be waiting for the ambulance with a patient who is deteriorating?
Very much from a nuts and bolts perspective, it means that you've still got the patients and the duty of care is active and ongoing, and you can't pause that responsibility whilst you're waiting for the transfer to arrive. So from a practical perspective, there's just more work to be done in terms of looking after that patient, and that's time consuming, obviously. From a practical perspective, that you can and should be doing in terms of trying to understand what the response you're receiving is going to be like, whether or not there's anything extra that you can do, what fits within your own personal scope of practice, whether or not there are things that you could do to extend your scope of practice by asking for support or advice, either from within the ambulance service, from critical care outreach, or from your local ED as well. So there's quite a lot going on. Ethically, ultimately it means doing the best you can with the resources you have. That has to be sort of set within the framework of your scope of practice and recognising your limits. And that can be really challenging sometimes. But I think actually, if you invest a bit of time in giving some thought to what it is you can do, what it is you can't do, and where your scope of practice lies, and feeling quite clear and comfortable about that, then that really reduces the ethical workload in those more highly charged situations. Then it's exactly where strong primary survey skills matter, recognising you can't deliver definitive care, but definitely being solid and knowing that you can do the basics well and you can do those confidently, you can recognise deterioration, know how to ask for more help, All of those things are really important. And the other sort of practical and ethical dimension to this is being clear about ceilings of care as well. And I think we are good at this in primary care. Preparedness is not just about always escalating. It's also knowing about when escalation isn't appropriate and being able to identify and manage that confidently and compassionately with patients and their family members, when perhaps actually not calling the ambulance or not escalating to hospital is more appropriate.
And how would it differ if you were in a rural care setting where you don't have easy access to an emergency department versus in an urban practice where services are easier to access?
The main and obvious difference is time, the travel time, and it's always been a challenge for rural practices more than urban practices, just by the sheer virtue of being, my practice is 40 minutes away from the ambulance centre, then it's going to be 40 minutes for an ambulance to arrive with me, unless one happens to be passing, and that doesn't happen very often. If we're only 5 minutes away from the ambulance in an urban setting, then that's fairly obvious. There's a load of different factors in terms of the relative busyness as well. In an urban setting, you might not expect to get your ambulance within 5 minutes because they might very well be out with another patient because there's a larger population there. So, but time is the big and obvious thing. But it's also a little bit to do with case mix as well. In an urban setting, I used to find many of my patients who might have experienced injuries or were more unwell would just bypass me and go directly to the ED entirely appropriately. I find in rural practice that they come to see me. They're often sicker when they come, but it's great. They're with me so that we can start making that assessment and initiating that treatment whilst we're waiting for the help to arrive. It's the right thing. Nobody's making the wrong decisions here. I think there's a lot in the press at the moment about people making the wrong decision about where to go. These are patients making the right decision, but the emphasis is somewhat different. And then that emphasis shifts to holding the patients in a safe place for longer. And so we're more used to, and we have always been more used in rural settings to caring for patients who are more unwell for a bit longer whilst we've waited for an ambulance to come. I think that one of the big things that's changed across the board then with ambulances stacked outside of A&E departments is that urban practices are starting to experience what rural practices have experienced for a long time. But in both settings, the underlying skills are the same. It's still ABCDE, it's still doing the basics well. It's just that in rural settings, probably just need to sustain that for longer.
Yeah, that makes sense. Thinking about out-of-hours providers and care homes and remote clinics, how should they think differently about emergency equipment and preparedness?
Environment and context are really important, and knowing your patients, knowing your case mix are really important things. So out-of-hours providers might well sit sort of close to the higher risk end of the spectrum because there's multiple factors. There's often fewer staff around, less immediate backup, potentially higher acuity. And so out-of-hours services, my out-of-hours service that I work with locally, we've worked together to develop a very robust standardised approach to assessment and stabilisation. And actually the equipment that's available has been reasoned through and risk assessed into place in a very effective way. It's not to say that other practices, GP surgeries, won't have done that, but I think it's a larger organisation where there's been more experience of higher acuity presentations. So the experience has been there to refine the equipment that's been kept. Care homes are a very different situation. They benefit probably most from strong recognition skills for deterioration and clear escalation plans, including ceilings of care, because actually every patient's different. So we need to know what the plan is for each patient. We're not going to make any assumptions that just because somebody's in a nursing home, they shouldn't be admitted to hospital. But equally, the fact that they are in a nursing or residential care home might be taken to suggest that there's a higher chance that a hospital admission might not be the right choice for them. And so having a clear understanding of that is really important. And then remote clinics, I think you just need to assume that isolation's the norm and make sure you've got good communications and the right equipment. But it's not about having advanced kit, it's about having the fundamental kit that you need to be able to do the basics well in place.
So you briefly touched upon equipment. What principles should guide a GP on decisions about what emergency equipment should be kept in a primary care clinic?
There's no one size fits all. It depends on where you are, and that it depends on your skill set. It depends on your staffing, the scopes of practice of the people who are there. It depends on your proximity to definitive care or relative remoteness from it. It's not to say that there isn't a basic sort of level of equipment that one should reasonably expect, and I think very reasonable to take from the kit lists for things like the immediate life support course would be a great place to start for that. But low value equipment often looks impressive but isn't used often, or it's hard to maintain, or it's costly, or it sits outside the regular competence of the team. But high value equipment often feels fairly standard, fairly mundane. It's the stuff to be able to do reliable observations with, effective oxygen delivery, and enough oxygen to last the duration, and or a system for getting hold of some more if you think that you might need some, either from a neighbouring practice or from community first responders. And then just really well organised, actually it's not necessarily having loads of kit, but just being able to lay your hand on the stuff that you need is really valuable. So making sure that things like the anaphylaxis and resus drugs are really well organised, that if you need an airway, then you can pick it up. And then, alongside this, because these are low occurrence events, making sure that there's also cognitive aids, checklists and flowcharts which help you to remind yourself of what you've been trained to do. So having the ALS algorithm clearly available, for example, so you can pick that up and say, right, where are we? I've got lost. What am I going to do? I think those kind of things can really help reduce cognitive overload and help you to see the wood for the trees then, because it's not just about then doing that conditioned response in terms of resuscitation and going through the chest compressions and the ventilations and getting a defib on or whatever becomes necessary. It's also, you need to take a step back from that and think about what reversible causes are there here. What am I going to do next to try and actually help this person to recover?
What difference does the staffing make in a primary care practice?
That makes a huge difference. And it's difficult to comment because, again, each team's different and the scopes of practice of individual practitioners are different as well. We're seeing a really positive development of the multidisciplinary team in primary care, including paramedics are a good example of people who've received very direct training to be able to manage patients who are critically unwell. That can really help. But of course, a paramedic who's done advanced clinical practice training and works more in a kind of general practice surgery environment will de-skill in those elements over time, just as I will have de-skilled when having moved away from working in A&E into working in general practice and urgent care general practice over time. Even though your core training might be there and some of that sort of remains as kind of muscle memory, the reality is that we de-skill with this unless we keep on practicing. The staff are really important. I really want to give a call out to the reception and administrative staff as well, because they play such a core role for us, and they're so frequently overlooked. And reception staff are often the first people to witness collapse or breathlessness or acute distress, and they're not clinicians. They do that through their experience and through their compassion. Being able to recognise concern and trigger that emergency response at an early stage is so important. And we need to do work within the team to make sure that they feel empowered to do that, because it makes such a big difference. It's just the right words spoken well at the right time can really build up them as a resource. The opposite is so sadly often the case as well, that just speaking slightly out of turn can really diminish their willingness to step forward and raise the alarm. So just getting the language right and managing the team is so important.
Can you tell us a little bit about the stabilisation and treatment awaiting transfer course and what it's designed to address?
This course is very much born out of a realisation that I had that what we were doing in rural general practice and my sort of bread and butter and my clinical norm had sort of been brought home a bit to roost in more urban settings as well. That with ambulances being stacked outside A&E departments, the wait time even in all practices was going up. And at least in my rural environment, with the experience over time that I built up, I felt fairly able to respond to many of these emergencies. I still find them stressful when they arise, but I felt better able to respond. And I think pivotally, we already had the right kit in the practice to do that, because we'd already gone through the process of thinking about what's likely to come in and what kit we needed to be able to respond to those events. And so realising that there was a sort of a training gap there, we designed this course very much to address the gap between recognising serious illness, then that time lag for arrival of definitive care, and particularly when that arrival of definitive care is delayed beyond the ambulance response programmes, urgent care, urgent response ambulance, sort of average time of 18 minutes, pushing things out. So we sometimes term it as the sort of the first hour or the first hour and a half course. And it focuses on nailing down really immediate life support level skills and primary survey principles in a primary care context, early recognition, structured assessment, first line stabilisation, repeated reassessment and team working whilst awaiting transfer. Whilst the immediate life support and the UK Resource Council training programs are very much based around that sort of operant conditioned response. Patient collapses and we get down beside them and start doing CPR. And those courses are brilliant for that. The stabilisation, treatment, await and transfer course, the STAT course, is all about then trying to contextualise and operationalise that and make it a little bit more, we've got the resus bit sorted, now let's think about the underlying causes, take a step back, trying to work out how we're actually going to initiate treatments, which is kind of next step, I suppose, from ILS. And we deliberately prioritise common and high impact emergencies. If you can do those well, then you're going to have that cognitive and practical framework to manage the lower occurrence events, the halo events when they occur.
What would you say is good enough emergency preparedness for a primary care team?
I like the concept of good enough, because good enough should be good enough as well, shouldn't it? So good enough means reliable rather than perfect, I think. I think that's really important. It means that every member of the team knows the plan, that they're familiar with the kit and they know where it is. And that's every member of the team, including the admin team, the receptionist staff, so that if, as sometimes happens, stuck in the patient toilet, these things happen all sorts of places. You might need to send somebody to get equipment rather than, or if it's in the car park, then we need to just make sure that we can adjust our response accordingly. Means that every member of the team knows their role as well and feels comfortable in that, so then they're not experiencing psychological trauma as a result of feeling like they should have been able to respond and not being able to. Good enough means that the ABC of the primary survey, ABCDE, is second nature, and it can be delivered so directly, consistently and in a timely fashion, that we're not dithering. And it means common emergencies have been practiced so that they can be managed calmly. The equipment's simple and it's well maintained and it's familiar, and we don't have lots of stuff there which distracts us from our core purpose. Alongside that, good enough is about being prepared so that we can reduce that cognitive load, so that we can take that step back and be able to work out and reason what's actually wrong with this person, what can we do to improve the situation, and being comfortable that there are limits to that, so that we're not feeling in a situation where we say, oh, I wish I could have done that, because outcomes aren't necessarily always positive. It's so that we can say we have recognised that there are limits to what we can do. We've ensured that we've got our skills together to do the best that we can, where we've got appropriate equipment available to be able to achieve that, and that if the outcome is adverse, because we can't always save everybody, if the outcome is that somebody dies as a result of their illness, that there really wasn't anything extra that we could reasonably have done to have been able to respond to that. That helps both the responder but also the family members of the person affected to feel confident that everything that could have been done was done. I think that's really important.
And what is your advice to practices that feel overwhelmed and not sure where to begin?
Yeah, where should you start? Start with the basics and start small. I think start with thinking about what's likely to be walking through the door and look at what equipment you've got and have a think about that. Take a bit of a sort of risk assessment approach is what I would advocate. Yes, some lists do exist. Start with a list of equipment. Go on an ILS course and think about the equipment you use on an ILS course, and I think that would be a really good starting point. But then think about what's likely to be coming through the door and think about your scope of practice, what your capability is, and then look at your resus trolley or your equipment trolley. Be really deliberate about it and say, this is what we're expecting to come through the door. Do we have the right equipment to be able to provide the response at the level we want to be able to respond to it, and what are the risks and benefits of having each different piece of equipment, and risk assess piece of equipment in or out of that trolley. Say, not having this is too great a risk. I would venture to suggest not having an oral or a nasal airway, for example, is probably too great a risk for most clinical environments. Not having anaphylaxis equipment, not having adrenaline and the means to give it, that wouldn't be appropriate. But perhaps having a full intubation set, that might actually increase your risk rather than decrease it, because you probably can't sustain the skill set to be able to use it. If you're 5 minutes journey time from a local A&E, then you might feel that having IV fluids on your trolley might not be relevant to you, or sustaining the skills to be able to cannulate is not something that you're able to do. But it maybe if it's 45 minutes, an hour, or an hour and a half travel time to your local ED, then perhaps having some fluids and the ability to give them might be more appropriate. And it's very context specific, but it needs to be a deliberate and reasoned out, thought out approach. But that doesn't have to happen overnight. So if you're feeling overwhelmed, as I say, start small, start with the basics, start with your ABCDEs, and think about the kit you'll need to be able to respond to those key aspects within your scope of practice or the scope of practice of your team. And it'll all build up nicely.
Thank you. That sounds like very sound advice. Finally, if you would like to change one thing about improving emergency preparedness in primary care, what would it be?
Well, this is great as well. I think it'd be really tempting to argue for a fully funded, standardised national emergency preparedness programme for primary care. Everybody should be funded to come on my stabilisation, treatment, awaiting transfer course, and then everybody be prepared and maybe layer upon that some form of mandated sort of emergency trolley review process. But I think that risks being very unrealistic given competing priorities, and why this over other really essential aspects of care as well. There's all sorts of competing priorities in primary care. So I think let's be more grounded. A really high impact and low cost intervention would be to raise the mandated minimum resuscitation requirement for clinical staff. And I feel quite strongly about this actually. The mandate basic life support plus AED, and it is just adult basic life support plus AED being the mandated minimum requirement for primary care staff is, I would say, woefully inadequate. So stepping up from that to immediate life support level capability, with layered on top of that at least some additional paediatric content, so at least paediatric basic life support, but some of the peds ILS content, recognising that it's probably unrealistic to get all primary care clinical staff to go through ILS and PILS, but I think that would significantly strengthen the baseline capacity of the workforce and their capability to respond. That's what I've done within our local out-of-hours provider, urgent care provider, Cumbria Health. I'm the clinical training lead there. It's precisely that I've organised, is so that all of our clinical staff have access to that sort of ILS level training. I think that single change would really, really make a massive difference.
Thank you so much, Tim, for this very insightful conversation. And thank you to our listeners for joining us. Don't forget that you can claim CPD credits for listening to these podcasts, and there are plenty more on the MIMS Learning website. I've been Sangeeta Krishnan, speaking to Dr. Tim Sanders, and this episode was produced by Jude Owen. Look out for our next episode featuring a studio discussion with the MIMS Learning editorial team. See you next time.